Good evening, ladies and gentlemen, and welcome to this continuing medical educational event called Circulate Thrombosis Forum. We have two excellent speakers tonight. This event is CME accredited and is endorsed by the Emirates Cardiac Society and sponsored by Pfizer. Our first speaker tonight is Dr. Walid Al-Tahlawi. He is a clinical associate professor at Case Western University in the US and a consultant cardiologist at Cleveland Clinic, Abu Dhabi. Our second speaker is Dr. Ammar Lal. He is a consultant oncologist and hematologist in Tawam Hospital in Al Ain. Dr. Tahlawi will start with the first talk, followed by Dr. Ammar. Dr. Tahlawi will talk about the SPAF from clinical trials to real evidence. Dr. Tahlawi.
Thank you so much, Dr. Wael, and thank you, Pfizer, for inviting me today for this hopefully excellent webinar to discuss our patient with atrial fibrillation. I will try today to translate the clinical evidence into clinical practice. So in a second, I will share my screen. Okay. Clear, Rania?
Yes, Doctor.
Okay, thank you so much. So good evening again, our colleagues. It's my pleasure to be here today to discuss how to protect our patient with atrial fibrillation. Without delay, I'm gonna start discussing our patients. So in my agenda today, I will discuss the burden of atrial fibrillation. I will review the evidence base of protection our patient with atrial fibrillation. And then I will discuss the anticoagulation in a special group of patients. And then I will tailor the evidence into real-time practice with discussing one of the cases with a challenging case. And then before I start, disclosure, apart from this meeting is sponsored by Pfizer. I don't have anything to disclose. First of all, what is the burden of atrial fibrillation? So atrial fibrillation, actually, that's the most common arrhythmia in our patients. I have a question here to start with to my colleagues. How many patients with atrial fibrillation worldwide? Is it 10 million, 17 million, 23 million, 37 million? And please answer and vote for which one of these numbers. I will wait for 30 seconds. And Rania, if you could also provide me with the answer. Rania? Okay, so actually the estimation, this is based on the data from US, we have around 37 million patients with atrial fibrillation. And this is based on the latest national data from US in 2020-21. When we're offline, I actually discussed with Dr. Wael regarding our burden of atrial fibrillation patients in UEE. He mentioned it's close to the international ratio. It's about 1% of the general population is at risk or having atrial fibrillation patients. So if we are considering the overall population, of UEE, so we have close to 10 million. So we have at least 100,000 patients of atrial fibrillation in UEE. So our duty actually to protect this kind of patients, we have a huge number of patients with atrial fibrillation. So if we know that in US, every middle-aged adult, 1 out of 4 is at risk to develop atrial fibrillation. So we have a 25% of the middle-aged adult in US and in Europe at risk to develop atrial fibrillation. And once the patient had an atrial fibrillation, the stroke incidence increased by 4 to 5 times. So 25% or 1 out of 4 of the middle-aged adult at risk of atrial fibrillations. And once it is developed, then he has a 4 to 5 times increase the risk of stroke. And once the stroke happens, then the patient has 2 times more fatal outcome of the stroke. Not only that, but also short-term mortality in 30 days in hospital mortality, it's about 25%. So it's clearly that we have a huge morbidity and mortality of patients. And again, our duty is to protect these kind of patients. Not only the incidence of atrial fibrillation is about 25%, but also it's increasing with the age. So again, this data from US and from Germany representing Europe, and you can see that in the x-axis is the age in years, and the y-axis the prevalence of atrial fibrillation patients. So as you can see, when the age goes up, then the prevalence also increases. And if you compare to the age of 65 to 74, we have about 6% increase in the prevalence of atrial fibrillation in US and about 10% in increase in the prevalence of atrial fibrillation in Europe. So as the age goes up, then the prevalence also increase. And remember, the advanced age of population is at risk of a higher risk of morbidity from atrial fibrillation, and at the same time, they are at risk of increasing bleeding risk. Also, the projection of atrial fibrillation patients with the expectation by the year of 2060, there is a huge increase in the patients' population of atrial fibrillation, and this is mainly driven by population at the age of 80 or plus, while the age group 65 to 78 is almost steady, but the patient with 80 plus years old is getting a higher risk of atrial fibrillation. So the total number is increasing, and it's mainly driven by the older population, aged more 80 years old. Again, if you look at the stroke risk increasing significantly with the higher age group. The patient aged 80 to 89 years old, they have a 23.5% increase the risk of stroke or atrial fibrillation related risk of stroke. So again, this is highlights the burden of ischemia in this kind of age of the population. At the same time, also increases the risk of bleeding. So we have to counterbalance between the ischemia, ischemic events protection, and the safety in terms of bleeding risk. So I'm gonna now discuss the overview of the evidence behind the protection of atrial fibrillation patients. We have, of course, the new classes for new oral anticoagulants. And before I do that, I have another question to my colleague. In which of the following circumstances it is most appropriate to do cardioversion before anticoagulation? This is 4 scenarios. The first one, the onset of the current episode of atrial fibrillation is not clearly within 48 hours, or there is no clot is seen in transesophageal echo, or the episode of atrial fibrillation has been present more than 48 hours, or the last scenario, if the onset of the current episode of atrial fibrillation is clearly within 48 hours, and the patient has non-valvular atrial fibrillation, and he is not at high risk of thromboembolic events. Again, I will wait for 30 seconds for the answers, please. So when the question again, when or in which of the following circumstances it is most appropriate to do cardioversion before anticoagulation? Usually we do anticoagulation and then cardiovert, but one of these scenarios, it is safe to cardiovert, then to start anticoagulation if the chest VASCO score is high. 30 seconds again. Okay, so clearly, if the episode of atrial fibrillation is less than 48 hours and the patient has non-valvular atrial fibrillation and he is not at high risk of stroke, then simply we can cardiovert this patient, then anticoagulate. So it's clearly the risk is low in this kind of scenario. Okay, then I'm gonna discuss now the big trials of new oral anticoagulants that discuss the evidence behind protection of our patients. We have Aristotle trial for apixaban, Relate trial, dabigatran, Rocket AF, rivaroxaban, Engage AF, TIMI 48 trial. This is for endoxiban. So I'm gonna start with, one second, yeah. So I'm going to start with Aristotle trial. This is a randomized double-blind trial in patients with atrial fibrillation and at least one additional risk factor for stroke. This is around 18,000 patients randomized to warfarin versus apixaban, 5 milligram BD, or 2.5 milligram BD in case the patient age more than 80. We have to have two criteria for reduced dose. If the patient age more than 80, weight less than 60 kg, or serum creatinine around or above 1.5 milligram per DL. So if we have two criteria of these three, so we give the dose adjusted regimen, which is 2.5 milligram BD. So again, warfarin versus apixaban, randomization is 1:1. The main characteristics of the patient's population is the mean age of 70 years old. The mean CHADS score is 2.1, and the mean time in therapeutic ratio the INR in therapeutic range was 62.2%. So they looked at the first outcome is protection, which is stroke, either ischemic or hemorrhagic stroke, and also the systemic embolization. And the secondary outcome is the bleeding or the safety outcomes, which is presented by intracranial hemorrhage, GI bleeding, and all-cause mortality. So in terms of the first outcome, which is the stroke and systemic embolization, we have in the apixaban arm, we have a 21% relative risk reduction, and the p-value was set for superiority. It was equal 0.01. So we have here superiority in terms of apixaban versus warfarin in terms of efficacy, which is stroke protection. In terms of bleeding risk or the secondary outcome or the safety outcome, we have 31% relative risk reduction. Again, this is B value was set for superiority, apixaban versus warfarin. And if you look at the lower right side of the screen, this is the middle line. Anything to the left of the middle line is in favor of apixaban. Anything in the right side of the middle line in favor of warfarin. And you can see in terms of all-cause mortality, intracranial hemorrhage, GI bleeding, ischemic protection, all they are in favor of apixaban, nothing in the warfarin side. So this study, this trial was powered for superiority in terms of efficacy, stroke protection, and at the same time safety. It was apixaban was superior to compared to warfarin. If we look at the other trial, which is a relay trial, which was studied for dabigatran 110 and dabigatran 150 versus warfarin, a probe trial in patient with non-valvular atrial fibrillation and at least one risk factor for stroke. The patient characteristics, the mean age is 71 years old. The mean CHAD score is 2.1, with the mean time to therapeutic ratio 64%. It's equivalent patient characteristic to Aristotle trial. If you look at the outcomes, so we have actually two drugs here, dabigatran 110 and dabigatran 150 against warfarin. So the gray color is the warfarin, the orange color is dabigatran 110, and the dark or the red color is dabigatran 150. The results of warfarin or dabigatran 110 versus warfarin actually was not significant. But the significant, I mean, in terms of stroke protection, but the significant stroke protection was observed in dabigatran 150 with a 35% relative risk reduction. And this is superiority in terms of dabigatran 150, but dabigatran 110 was not statistically significant. But if you look at the safety outcomes or the safety endpoints, if you look at the again, warfarin, the gray, orange is dabigatran 110, and the red one is dabigatran 150. So in terms of major bleeding, dabigatran 110 was superior to warfarin in terms of safety. But remember, in terms of stroke protection, was not superior, was not statistically significant compared to warfarin. So in terms of dabigatran 150, it was significantly statistically non-significant in terms of safety. So the event rate in terms of major bleeding observed in warfarin and dabigatran was the same rate. So the conclusion of this trial is 110, dabigatran 110 in terms of efficacy was not superior, in terms of safety was superior. Dabigatran 150 in terms of efficacy was superior, but in terms of safety, it was the same as warfarin. So it's not superior to compared to warfarin. And if you look at the lower side, lower part on the right side of the screen, this is the outcome. This is the middle line. Anything on the left side of the middle line is in favor of dabigatran, and anything on the right side of the middle line is in favor of warfarin. So the outcome was observed in dabigatran arm, except 150, there was a major rate of bleeding in the dabigatran group. That's why in terms of low GI bleeding, warfarin was better compared to dabigatran 150. The same for ischemic stroke for dabigatran 110. Again, warfarin was better, slightly better. However, statistically was not significant. So the bottom line of this Relays trial is 110 was not superior to warfarin in terms of stroke protection, but dabigatran 150 was superior in terms of stroke protection. On the other side, major bleeding, 150 was not superior. However, dabigatran 110 was superior. In terms of Rocket AF, this is rivaroxaban against warfarin. To be honest, this trial is a double blind randomized controlled trial in patients with atrial fibrillation. at moderate to high risk of stroke, compared to Aristotle and Relate trials, which was powered for moderate risk patients. This patient has a higher mean CHADS score, 3.5, compared to 2.1. The mean age was similar, 73 years old. The mean time and therapeutic ratio was 55%. So if you look at the results, warfarin compared to rivaroxaban, 20 milligram OD or 15 milligram OD if creatinine clearance, I would say 3P from 30 to 49. So in terms of stroke protection, the event rate happened in two arms at the same time, so it's not superior to warfarin in terms of stroke protection. Again, for safety, for bleeding risk, for the bleeding risk, again, was not superior. So in terms of all-cause mortality, intracranial hemorrhage, GI bleeding, stroke protection, there was a slightly benefit from rivaroxaban compared to warfarin, but again, this was not significantly statistically significant, except the rate of intracranial hemorrhage was lower in the rivaroxaban group compared to warfarin. So the conclusion of ROCKET-AF trial is rivaroxaban versus warfarin was not superior in stroke protection. Again, it was not superior in protection against bleeding risk. Engage atrial fibrillation trial for endoxiban. It is similar to ROCKET-AF trial. It is a randomized double-blind controlled trial, double DOMI trial, which is two types of placebo. It was designed to protect patients with moderate to high risk patient of atrial fibrillations. Again, the mean CHADS score was 2.1 compared to 3.5 for ROCKET and 3.5 for ROCKET and 2.5 for Relay and Aristotle. If you look at the results, endoxiban 60 milligram OD or 30 milligram, and if the patient is less than 60 kg, or creatinine clearance from 30 to 50 milliliter per minute. If you look at the results, warfarin compared to endoxiban, so it was not significant. If you look at the in safety, so there was 20% relative risk reduction, which practically is superiority in terms of endoxiban compared to warfarin. But this is of safety. But what about stroke protection? It was not significant. Again, if you look at the lower side of the screen, anything on the row and the left side of the middle line is in favor of endoxiban, and anything on the right side of the middle line in favor of warfarin. So there is no statistical significant difference. If you look at the stroke protection, it's almost in the middle. The only positive or statistically significant event was intracranial hemorrhage was lower in the endoxiban. So yes, it is more safe compared to warfarin, but it was not superior compared to warfarin in stroke protection. This is exclusion criteria for randomized controlled trials. It's a collection of the exclusion criteria. It is a lot, but I want to highlight here two things. Number one, the population of recent stroke was enrolled in the Aristotle trial. It was within 7 days. However, in Relate trial, the stroke patients who enrolled this trial was within 14 days or within 6 months if the stroke was large. The same thing for ROCKET-AF trial, patient with recent stroke was within 3 months, or any stroke within 14 days was not rolled in the was not included in the trial. Engage trial, also a stroke patient within 30 days was not included in the trial. So recent patient with recent stroke defined as 7 days in Aristotle trial, Relay trial within 14 days or 6 months if it's severe, Rocket atrial fibrillation within 3 months or 14 days if any kind of stroke, or stroke within 30 days was excluded from the trials. So meaning that anything beyond these criteria was included in the trial. And this is very important when we discuss the protection of atrial fibrillation patient with recent onset of stroke. Another important point to highlight the exclusion criteria from the trials, the kidney function. The lower creatinine clearance was included in the trial, was 25 ml per minute in case of Aristotle. However, the rest of the trials included patients above 30 ml per minute creatinine clearance. So now I'm going to discuss the anticoagulation in a special group of patients. Actually, special group of patients is huge, but before starting this, I have another questions. When it's safe to start oral anticoagulation in a patient with recent stroke, and please vote. I will wait for 30 seconds. So usually it is safe to start anticoagulation or to resume anticoagulation after recent stroke if it is more than 2 weeks. Yes, we can start within 1 week, but only if this one is a small stroke or TIA. But for a moderate size stroke or larger stroke, we have to wait at least 2 weeks before to start the anticoagulation or to resume anticoagulations. So now I'm going to discuss the patient with acute stroke, how to protect these patients. We have very nice schematic approach to patient with acute stroke or TIA, how to protect these patients. So typically it's based on the size of the stroke. So we have TIA, mild stroke, moderate size stroke, and severe stroke. So moderate and severe, it means that we have a moderate or at least a significant neurological deficit. And also we have imaging evidence that the stroke is large. So we have, to make it simple, we have 1 day, 3 days, 6 days, and 12 days. So in TIA, we can resume after 1 day. In mild stroke, we can resume after or to start after 3 days in minor stroke. And in moderate to severe, we have to wait 1 week and 2 weeks in case of severe stroke. So we have to have, again, an evidence that there is no hemorrhagic transformation after starting or resuming the anticoagulation in such kind of patients. So it's very easy. So 1 day, 3 days, 1 week, 2 weeks, according to the stroke, which is TIA or mild stroke or moderate stroke or severe stroke. The question usually very challenging if this patient is on anticoagulation and have another stroke. So should we resume the same type of anticoagulation or should consider another or adding another antithrombotic agent? This is a really big question for debate. So this trial addressed the question of resumption of oral anticoagulation after recent stroke, and it showed that after 1 year follow-up, there about 10% reduction of stroke events after resumption of anticoagulation after the ischemic stroke. At the same time, there is no statistical significant difference in terms of hemorrhagic complications in both groups. Another important mortality benefit after resumption of oral anticoagulation after recent stroke, after 1 year, we have more than 22% increase in mortality benefit. I mean, there is a survival benefit of 22% after resumption of oral anticoagulations in this kind of patients. So it is important to resume anticoagulation as soon as possible. The patient developed stroke. At the same time, we have to address the possible hemorrhagic transformations. So another study confirmed that the primary outcome, which is composite endpoints of recurrent ischemic stroke, intracranial hemorrhage, and mortality. And this is the middle line. Anything on the right side is in favor of oral anticoagulants, and anything on the right side in favor of vitamin K antagonists. This is retrospective analysis and showed that either the composite endpoint or the secondary outcome, which is the individual endpoints, is in favor in resumption or resume the oral anticoagulation after the ischemic stroke without increase the bleeding risk. So another special type of patient with GI bleeding. So GI bleeding is critically important because it's common, and our patient is most likely is in higher age group, which is a higher risk of GI bleeding. And from the study that we have discussed now, we have evidence that the warfarin, dabigatran, and rivaroxaban increases the risk of GI bleeding compared to apixaban. So in terms of the site of bleeding, we have evidence that the lower GI bleeding, it occurred more in dabigatran and rivaroxaban compared to warfarin. And this is because that GI bleeding, actually, the upper GI bleeding decreases the absorption of dabigatran and rivaroxaban in the upper side of the gut and leaving the risk to the lower part of the gut. So in terms of upper or lower, lower is more common in dabigatran and rivaroxaban. This is a collection of the results of the randomized controlled trials, warfarin versus the individual oral anticoagulants. We have here on the left side, the orange is the warfarin, and the light blue or light beige is dabigatran 110. There is no statistical significant difference in terms of major bleeding between warfarin and the dabigatran 110. But again, remember, there is no superiority in terms of stroke protection. In terms of dabigatran 150, there was a statistical significant difference between warfarin and dabigatran 150 in terms of major GI bleeding. So there is increased event rate in the dabigatran 150. In terms of rivaroxaban, again, similar thing. Increased event rate in terms of major bleeding in rivaroxaban 20 compared to warfarin. However, in apixaban 5 milligram, there was no statistical significant difference between apixaban and warfarin in terms of major bleeding. So it's clearly with dabigatran and rivaroxaban demonstrated a statistically significant increase in the number of major GI bleeding compared to warfarin. Again, this is a retrospective analysis. It's 280,000 patients from real-world practice, what's called an Aristophanes trial. It's compared different NOAC versus the others. There is no randomized controlled trials compare the individual classes of new oral anticoagulants against each other, but this is retrospective analysis. And again, it demonstrated that the stroke protection in terms of apixaban versus dabigatran, there was 28% reduction in favor of apixaban. In major bleeding, there was a 22% reduction in favor of apixaban against dabigatran. And GI bleeding also was 34% lower in apixaban versus dabigatran. Apixaban versus rivaroxaban also observed a 20% event reduction in stroke protection. And the same thing for major bleeding and GI bleeding. There was a 45% and 52% respectively in terms of major bleeding and GI bleeding. So apixaban actually offer a favorable effect versus warfarin and the other new oral anticoagulants in terms of stroke protection and lower rate of major GI bleeding in patients with atrial fibrillations. Again, this is apixaban versus dabigatran, apixaban versus rivaroxaban retrospective analysis from a large population database show that there is a statistically significant difference in terms of major GI bleeding toward apixaban versus dabigatran, almost 30%. Again, meta-analysis showed that about 90% of the patient in the meta-analysis showed that the significant lower GI bleeding in case of the apixaban. For the sake of time, I wanna just go ahead and what's written in the guidelines in 2020 guidelines, ESSC guidelines. It's clearly stated that in a patient with a recent bleeding event, attention should be directed towards addressing the predisposing pathology, and then for the reintroduction of new oral anticoagulation, we should consider apixaban or dabigatran 110. But again, remember that 110 was not statistically significant in terms of stroke protection. Again, expert recommendation from European Society of Cardiology, patient with high risk of GI bleeding, apixaban should be considered, or dabigatran 110 should be considered in these kind of patients. So I'm gonna discuss one patient from the practical standpoint. So I have one patient, 92 years old female patient with history of EF of 15%, moderate to severe aortic stenosis, creatinine, chronic kidney disease stage 3, hypertension, hyperlipidemia, osteoporosis, chronic anemia, bronchial asthma, and limited mobility, multiple risk factors, and in its 92 years old. So this is her ACG, showed atrial fibrillations. So now this patient has atrial fibrillation, and what is her ischemic and bleeding risk? So practically, we have to estimate her CHA2DS2-VASc score and has bleed risk score. This is her problem list just to help us to estimate the CHA2DS2-VASc score. For the sake of time, I estimated it was 5. So it has anything above 2, it has a high risk of stroke. So its anticoagulation is indicated in this case. But at the same time, her has bleed risk score was 4. So also anything above 3 is high risk. So we have 2 risks, ischemic risk and bleeding risk. So what to do in this case? It's very difficult and a challenging question, but I will recall some data from Aristotle trial. This is apixaban versus warfarin. Again, confirm that the rate of major bleeding across the age group was in favor of apixaban. And this is subgroup analysis, apixaban versus warfarin, again from Aristotle trial, showed that consistent protection with a lower bleeding rate in patients either on apixaban with history of GI bleeding or apixaban with no history of GI bleeding compared to warfarin with or without history of GI bleeding. So again, this is confirm that the fact that starting this patient on apixaban probably less risky compared to warfarin and other new oral anticoagulant. Then I decided to start this patient on apixaban 2.5 based on the fact that her age is 92 and her creatinine is more than 1.5 milligram per ml. And then I continuously follow up this patient, and her hemoglobin is in the range of 70 to 80s and with no signs in terms of anemia like heart failure, tachycardia, or shortness of breath. So she has been stable. And then we just only continue observing this patient. We did our best to change her bleeding profile, control her blood pressure, for example, and then the patient is relatively stable. And then I will stop here, and thank you so much, and I'm happy to have any questions.
Thank you, Dr. Walid. Our next speaker is Dr. Ammar, and he will talk about VTE in cancer patients.
So thank you very much, Dr. Walid. And Dr. Walid, very nice overview. I learned from your presentation. I will also implement, what you have, here, put data. I will show you similar way. So, good evening, ladies and gentlemen. So we are going this way. Yes. So now you have seen the data, like bench to bet by Dr. Walid with examples. So I will focus mostly on VT in some comorbidity, and especially is my domain, cancer patient. I will talk shortly. So in next 20 minutes, I have divided my talk 5 parts. First, I will go through the eye-opener, DEOX guideline, and D3, what is the dose, danger and duration, and the most important thing, which I am going to talk, specific comorbidity in our patients like cancer patient, having also with renal insufficiency, hepatic impairment, and some extreme bad VATs. Now, third thing, which I will go to research and resolve, the challenge is to show some pivotal trial, cutting edge data. And the important thing is, how to monitor the DEOX and how to reverse it if it's something happened, bleeding. And then summary and take home. And my final question with you people, that how do you predict DEOX in 2023? This is $1 million question. So now, how do you manage DEOX in special scenarios? Which guideline will you treat in hematology and oncology? This is for all of you information. We use actually NCCN guideline, and sometimes we use expert online. So now if I go by NCCN guideline in cancer patients, which treatment should be given for venous thromboembolism, and it is clearly mentioned here, preferred is the DEOX. So first is epoxybon, and then endoxybon, then evoxybon. And if there is problem with the GI, then second option is actually low molecular weight heparin if GI problem. Otherwise, this was the option was the DEOX. And in some circumstances like HIT, we use fondoproxen, and sometimes we use warfarin. So this is how. Second question is, if progression of new VTE, how to switch it? So we'll discuss later. Now, DEOX, as already mentioned, there are 2 DEOX. One is direct factor, which we call the XA inhibitor 10A. So it all comes from, you can say by name, whether epoxybon, XA will come, is 10A, all come together. It is direct factor 10 inhibitor. Other is direct thrombin inhibitor with Depactron. Now, you have seen Dr. Walid's presentation with why, now people are using, everybody know that's less frequent follow-up, less monitoring, immediate side effects, fewer drug and food interaction. So our past decades, we have seen that they have extensive investigation and they have scenarios. The purpose of this is to develop algorithm, how to navigate the patient in special circumstances, comorbidity, and especially the patient who bleed, and all these things we will discuss. Now, anticoagulation license for DVT and pulmonary embolism. And DEOX, there are 2, as I mentioned. One is with the help of low molecular heparin like Depactron and endoxybon, but epoxybon and rivaroxaban can be given directly. And this is how all over the world the people follow accordingly. Now, the risk of VT is highest in first week, and then followed by, you can say, up to 3 months, risk go down. So that's why usually we give VT treatment for the 3 months. Now here you see treat for the 3 months and reassess. If the patient has isolated distal DVT and there is a reversible provoking cause, then the treatment is just 3 months. And if patient has cancer or indefinite therapy, or until cancer is inactive, you have to give continuously indefinite. And if the patient is unprovoked, then depending on certain factors, we usually check D-dimer after 3 months. If D-dimer is positive, then we'll go for indefinite therapy. Otherwise, you have to see risk-benefit ratio, we'll take it accordingly. And more is like if patient has second VT, we give for indefinite therapy for the DEOX. Now, coming to my topic, comorbidity, and to see the risk-benefit VT versus bleeding on the anticoagulation. So I will go first by cancer, then renal, then hepatic impairment. So now, burden of the cancer associated with the thrombus. VT is the second most prevalent cause of death in oncology patients. And such patients are also increased risk of arterial and venous thromboembolism both, and cancer site, stage, and treatment, and some therapies actually they contribute the risk of venous thromboembolism. Patients with cancer have high risk of anticoagulation related bleeding as well as VT recurrence. So it's a very important topic we are talking today. Now, why cancer have more thrombus? All venous thromboembolism, this Vercors trial we know, but this Vercors trial is more active, more affected in oncology patient because venous stasis is more because of prolonged bed and compression of the blood vessel by tumor, and there is more hypercoagulable problem, procoagulants, tumor cytokines, and some treatment. And endothelial injury is also more common, especially during some treatment and some putting online chemotherapy drugs. So these are all, activates the more causing the venous thromboembolism in cancer patient. Now, choice between the agent in cancer patient, we have three choices. VK, warfarin. This is the problem, monitoring, dose adjustment, drug-drug interaction. Second choice is low molecular heparin. This is also the problem is adherence because of continuous injection. And then last is the deox, so oral risk of bleeding is low, as already shown by Dr. Walid as well, and no monitoring. So that's why it's choice. Now, it is not only based on this, but also clinical trial has shown, this is oncology patients, solid tumors, about 700 patients. They have shown that low molecular weight heparin reduce 50% reduction of recurrent venous thromboembolism. So first, thing came after, it was more successful. Low molecular heparin is better than the warfarin. Now we'll see. This is also cargo study. They have shown also that deox is better than even low molecular heparin, less recurrence and less bleedings. And even here you can see randomized controlled trial, more than 2,000 patients, they favors also to the deox. So that's why, this is, I just wanted to show you why NCCN guideline, they put deox is the better, and then number 2 choice low molecular heparin, and number 3rd is actually warfarin. This is based on all the trials is shown, and then they put in the guideline. Now we have to consider the risk and benefit. Dr. Walid also mentioned you have to check, renal, GI, and you have to check accordingly which deox is better. And the important thing is sometimes we use in oncology patient deox versus low molecular heparin. Some patients are not able to get deox, but again the problem is adherence. Here you can see in this chart, low molecular weight heparin has less adherence as compared to the oral therapy. So it is again individualization of the treatment is the key. You have to take accordingly. So that's why in all guidelines in our oncology, ASCO, NCCN, ITEC, ASH, they have all mentioned deox is the first choice. Now, okay. Now, if you see, again, this is NCCN guideline. As I mentioned before, deox is the preferred choice, and then low molecular heparin is the second, and then third one is like fondapaxine and warfarin. Now, second comorbidity is like renal failure. CKD is major global public health, and the risk of atrial fibrillation is more in renal failure as is shown. And when, renal failure has happened with the oncology patient, it is again more challenging. Why more challenging? Normal and mild renal insufficiency is not problem to adjust the doses. The problem comes when the creatinine clearance go less than 60 or less than 30, even it is more failure. But the important thing we should understand, and Dr. Walid has also mentioned, the Depixon, rivaroxaban, they are excreted by the renal. Here you need a lot of adjustment, but apixaban, as it's excreted through the liver and feces, so it is, less chances of the dose modification. This is our guideline. They have shown that Depixon, rivaroxaban, you cannot use when the GFR is less than 30, but all the way apixaban can be used in various doses. Even with the low, like less than 15, you can use 2.5 milligram even once a day as well. Now, CKD with moderate renal insufficiency, Here are also favors. There's all the meta-analysis, they have shown favors to the deox as compared to the warfarin. And it is also shown also not only thromboembolism favor, but major bleeding and all the cause death, their favor in the deox. And now the thing is, which deox is better? Again, this is meta-analysis. Here you can see the favorism goes to the which one, stroke or thromboembolism. The most favorable is the epoxybond, followed by rivaroxaban, then warfarin. And major bleeding, again, is favorable profile fall in the epoxybond. This is already Dr. Walid has mentioned. This is also emphasized in our data as well. Now, this is a Journal of American Heart Association, so that's why they have also mentioned saying, like if renal function is normal, you can choose anyone, but if it is less than 30 or less than 50, you have to adjust the dose of other deox, but epoxybond, you have to adjust only just when there is less than 15 GFR, then you have to adjust epoxybond, otherwise you can give the good dose of epoxybond. So in renal insufficiency, patient with a CKD are the high risk of arterial venous thromboembolism and major bleeding complication. Despite of renal excretions, deox seem to be favorable risk-benefit profile as compared to the other medications. However, the data less than 30 or less than 15 is some scarce, so more data is required, which deox is better. Now, second thing, in our oncology patient, they also, hepatic impairment as well also affected. And as we know, we check this child score, and no dose adjustment is required in all the deox if child A, but there is contraindication almost all when it's child C, but with the child B score, you have to modify the dose. Now, fourth is body weight, extreme body weight. If normal body weight is no problem, no dose adjustment required, but with severe body weight, you have to check and you have to go accordingly. You can choose actually rivaroxaban or epoxybond. And similarly, if body weight is less than 60, you have to check also epoxybond or epoxybond can be given adjusted dose. Data already presented by Dr. Walid. I just show the cutting edge the data, meta-analysis evidence faced by the deox versus the warfarin. They have shown in all the creatinine clearance, age, and in cancer patient or no cancer patient, all favors to the deox. And which deox, again, I amplified trial, they have shown they favors all in all the age and renal and weight, all the favors to epoxybond. Now, how to monitor it? Monitoring is actually here bit difficult as compared to, it's actually not needed. If it's not works and if there is problem or any minor bleeding happen, you have to check to level of these medications. The only monitoring the way is you can check is anti-factor 10A levels, which deox you are using, you should have availability. You have to check anti-factor 10A level, and then you can do accordingly. If progress, the new VT happens, if during deox, then how to switch again. As guideline mentioned, as I mentioned, you have to check to anti-10A level of that particular medication, and then you switch accordingly. Now, this is the data which Dr. Walid mentioned that, this is how from 2011 till now, this is the deox is going high and warfarin is going down. This I mentioned, deox. One person is GI. Who is GI? Actually, this is patient, easy to use, no laboratory control, and lower bleeding risk except GI. So he's happy. But who is in trouble? And some person feels sorrow. We actually was sorrow when we sorrow till 2018. Difficult to differentiate, especially typical laboratory control. If patient bleed, then what happened? But now this problem is solved in 2018 and 19 when antidote has come, which is called aducanumab alpha. So this is how I pull out, one quote that there are 4 degrees of intraoperative hemorrhage. Why did I get involved in this operation? Why did I become surgeon? Why did I become a doctor? And why was I born? This what happens to us when there was no antidote available to the deox. We always think like, why I was on call today? Why did I become physician? And we, our head scratch that why I am hematologist, why I was born, what is the antidote, what should I do, patient bleeds. But now this problem is solved. Now in 2023, we have bread and butter of emergencies, A to G, airway, breathing, circulation, discontinue medication, and go through the guideline. And there is clear guideline. There is antidote is available, and androstenedione alpha, which is by FDA approved in 2018 to reverse the deox life-threatening bleeding. Now, how to reverse the effect in elective and emergency patient in the deox? So if patient is going for surgery, as depends on the half-life. As you know, all deox, they have half-life somewhere between 8 to 12 hours. So you have to see 3 to 4 half-lives. It means you have to stop medication before going any surgery 2 days. If it is any patient is going for any major surgery, maximum 3 days you can stop, and after 2 to 3 days you can stop. You can start again deox. Otherwise, you can do bridging with the heparin if it is bleeding is prolonged after surgery. Now, if patient has bleeding, and the bleeding is a life-threatening bleeding, it's major bleeding like intracerebral bleeding or anything, what you have to affect the reverse the emergency. Again, as I mentioned, now as per guideline, we have androstenedione alpha, which actually directly affects, this is monoclonal antibodies. Otherwise, if you don't have these options, you can use PCC, another factor, but honestly, these not work as compared to androstenedione alpha. This works more than 80 to 90% in emergency. So now, what we conclude that DOC have revolutionized the treatment of the stroke, especially atrial fibrillation, which mentioned by cardiologists, even our venous thromboembolism in oncology patients. So there are many factors you have to check to choose the deox. Which deox is very important. You have to check the renal, hepatic function, and you have to go accordingly to deox, which is suits to the patient. One size doesn't fit to all. So in last 20 minutes, what I did, I went through deox, the guideline. I went through D3, dose, danger, and duration. An important thing, I went through the challenge to solution, the specific comorbidity, especially cancer patient, renal insufficiency, hepatic impairment, and extreme body weight. And I show you some cutting edge data and how to tool and to monitor the deox and how to monitor, especially electively and emergency reversal. Now we have antidote to cover all these anti-10 inhibitor. And finally, summary, and this is take home. And my final question, which is I would say $1 million question: how do you predict deox in 2023? You have to choose like warfarin, conventional heparin, low mercury heparin, Depacton, apixaban. You have choices of all these, and this is your choice what you want. So this is my final question. So thank you very much.
Thank you very much, Dr. Lal. And thank you very much also, Dr. Tahlawi. And we're now open for questions. If you could please put your questions in the chat.
Great talk, Dr. Ammar, mashallah.
Yeah, thank you very much.
Dr. Ammar, when you get a patient with a VTE, a cancer patient, do you admit to use the DOAC or do you do it as an outpatient?
Yes, good question. Normally, no. Until and unless, risk of any bleeding, anything, we don't do. Patient go from, from emergency. Suppose any new DVT, pulmonary embolism, a patient is not symptomatic, we don't admit naturally. If, there is no severity of the symptom, they will go to patient as outpatient, no need of admission.
So, because a lot of people are reluctant to a lot of people like to start heparin first and then switch to a DOAC. But in your experience, it's quite safe to start a DOAC straight away and send the patient home.
Again, it's not my even experience. I showed the guideline, like deox is the preference. Before it was not preference. As I told you, as I put there was quote as well. We were, scratch our hair, because of the problem. There was no antidote and so many things. Now, we are very safe road now, a safe guidelines, safe dose adjustment. If any oncology patient or any patient who having renal insufficiency, hepatic insufficiency, you have to check the dose. You can start. You can monitor accordingly. This is again, I mentioned one size doesn't fit to all, depending on patient profile and comorbidity. Yes, we can use safely as an outpatient, very safe. We use it now. Yes.
Excellent, excellent.
So I have one case for discussion, Dr. Wael.
Go ahead.
So I have a young lady with breast cancer. Her age in the range of 30s. Her breast cancer is active. However, she received she has a radical mastectomy and she received a complete cycle of chemotherapy. And then she has right atrial thrombus by echo. And we know that NOAC or DOAC is not validated yet for intracardiac thrombus. So, but her right atrial thrombus is organized. It's clearly well organized. So she doesn't have evidence of DVT or pulmonary embolism. So Dr. Ammar and Dr. Wael, what do you think to manage this patient? How to manage this patient? Is it anticoagulation versus no anticoagulation? And which type of anticoagulation if you decide to anticoagulate this patient?
Yeah. Dr. Wael, you want to go? I should go.
You can start.
Okay. Actually, so it is, she has only this one venous thromboembolism. She has not anywhere else. No DVT, other side.
No, it's well organized. The left atrial thrombus, right atrial thrombus, and the size around 1 by 2 centimeter. It's well organized by echo, and the follow-up echoes after 6 months, in 6 months interval, it's the same.
And you have checked everything, D-dimer and all the things.
Yeah, she is not manifesting by any kind of thromboembolic complications, but she has left atrial thrombus, even by cardiac MRI, showing this thrombus.
Okay, she has cured cancer. I mean, all the things done, or is still?
She has surgery. She has completed chemotherapy, but actually, as far as I know, she's active, but I don't know until when she's active. She completed chemotherapy, but by definition, as a cancer patient, is it completed? It's already cleared, or?
No problem. I can help out. See, now I understand your point. So it means the patient, breast carcinoma, who has undergone surgery, has completed chemotherapy, radiotherapy. Maybe she's on any hormone therapy. We call it the tamoxifen. That called venous thrombosis.
Yes, she's still.
So it's still, okay. So this is the problem, tamoxifen causes, severe venous thromboembolism. This can be the reason, one of the reasons. We have to off this one temporary, and we can start this patient, in this scenario, I would start low mercury heparin rather than, deox. Keeping our, risk profile, patient has tendency of, bleeding, anything. So I think in this patient, the safe side, I will go low mercury heparin rather than deox. Again, it's my personal, although if you go by guideline, even they say, you can give it. Only second choice is, like patient has GI problem, otherwise everybody's deox. But practically we do in these type of patient, a low mercury heparin, again, 3 months at least, and then we can check it. But I would also suggest, switch to some other hormone therapy. Tamoxifen is causing severe venous thromboembolism. So we have to off this one. We can choose other one, which is a safer hormones. Yes.
So you are going to give 6 months low molecular weight heparin.
Yeah, 3 months. 3 months, and then we check. If it is fine, then you can switch it. Even after 6 weeks, you can do, cardiac function, echo, everything you see. If it's fine, everything. After 6 weeks, you can switch to deox as well. After 6 weeks, yes.
Okay.
There's a related question here. If the patient has taken chemotherapy, what is the preferred anticoagulant?
On chemotherapy.
Yeah.
On chemotherapy, I already mentioned, this is as per guideline, deox is the preferred now choice. until unless patient has not any GI problem or GI malignancy. If it is GI malignancy, the choice is low molecular heparin. Other than GI malignancy, all the malignancies should take deox. And if renal function is fine, full dose. If renal function is impaired, you have to adjust dose accordingly.
Dr. Walid, if a patient with atrial fibrillation and mechanical valve had a stroke, when to restart warfarin?
When to start?
Warfarin, yeah.
Yeah. So
after stroke.
Yeah, it's according to European Heart Association for rhythm. Then practically according to the stroke risk, if it's moderate or large or minor stroke. So according to the size, we can, if it's moderate to large, we have to wait at least 1 week, and then we start warfarin, and we have to follow up by CT or MRI, and then to confirm there is no hemorrhagic transformation, then it is safe to continue. But it doesn't matter if the patient if it doesn't matter warfarin versus oral anticoagulant, except if the patient has mechanical valve, an indication for warfarin. But let us say the patient has no other indication for warfarin, then the same indication for oral anticoagulant. We have to wait at least 1 week for moderate to large stroke, and if minor stroke or TIA, 1 day or 3 days for minor stroke.
Okay, another question here, how to switch from one NOAC to the other?
One NOAC to the other. So
yes.
practically, I don't know why we want to choose to switch, but let us say
that's the question.
Okay, that's fine. So practically due the next dose of the anticoagulant. I mean, if it's apixaban, for example, which is taken twice per day. So when it's due the next dose, then we can give them the other anticoagulation, and then we continue from there. That's it.
Yeah,
okay.
Perfect.
There's a few questions on creatinine clearance less than 25, and I'll add also dialysis. What's your approach now? If you just have this factor and you don't have the factor of weight and age?
Yes. So I will back to my case, which was discussed now with Dr. Amara and with you, Dr. Wael. This patient, I discussed with her all the options. I provide the patient with the right atrial thrombus, and then I get her consent that probably we can start her on NOAC, despite this not the standard of care, because she doesn't want to get the injection. Then I'm following her every 3 months with an echo. There is no increase in the size of the thrombus and no complication from NOAC. So the same concept, it's case by case. We have cases already now, and GFR less than 25, and another patient on dialysis, and they are on a reduced dose of, or renal adjusted dose of whatever the kind of the NOAC, and then they are doing fine, by the way. But again, CHAD FASCO score of 3 is different from CHAD FASCO score from 5, from 6, for example. So the higher risk, the question about the efficacy, especially if it's not studied in randomized controlled trials. So the short answer is yes, we have patients in GFR taking NOAC in GFR less than 25. But this is discussed with the patient, and the patient preferred not to do INR, for example, every week or month, and they opt to choose the NOAC despite there is no strong evidence. So case by case, bleeding risk for the ischemic risk also should be taken in consideration.
So I would add here 2 points. I would agree with Dr. Walid. Dr. Walid, this is now a standard of care. As I mentioned, NCCN guideline, all over the world, people follow it. So you can tell your patient, this is standard of care, first of all. If you choose epoxyban, it's fine. Because as I mentioned, by guideline, you can choose GEOX and you can monitor. So this is one thing. And second thing, regarding, GFR 1530, I showed some, some guideline, especially cardiology guideline. They have mentioned even GFR less than 15. Epoxyban is recommended, 5 milligram OD dose. And even some European guidelines, they have mentioned also second thing. And third thing, the patient who was in dialysis. I showed one slide, I remember, the patient who dialyzed. There is a group of the patient, it's actually based on 30 patients, it's very small data. They are also on apixaban, so they use it, apixaban even, end-stage renal disease, dialyzed patient, so far safe. But again, in these patients, we have to monitor by factor anti-10A apixaban. This is the specific, each DOAC anti-10A is different, markers. So this is, if you have laboratory available, you can check it. This will be fine. If it is under the level, and if GFR suppose 10, but you are giving apixaban suppose 2.5 milligram jelly, and it is within the range of the anti-10A level, you check once, and then next month, then after 2 months, if it's mentioning the normal level, then you can go safely. Yes, thank you.
Yeah, I mean, as you both said, there is no data on this lower creatinine clearance. However, we do know there is data that warfarin is not safe in this group either. In fact, there is some data in renal dysfunction with warfarin that worsens renal dysfunction. So we know that, and in my experience, more recently, there is an FDA indication. The FDA does allow to use it, but again, it's not based on data, it's based on pharmacokinetics. But more recently in our practice now, for those patients on dialysis or low GFR, just pure low GFR without the other two risk factors, the dose that I use is 5 BID. If the patient does have another risk factor, then I will drop it to 2.5. And so far, we haven't had any issues with these doses. Because again, you have to individualize and risk stratify these patients. The next question, do you use DOAC in TAVI or in TAVR?
Yes, the short answer is yes. But not for the TAVR, for atrial fibrillation.
Atrial fibrillation, correct. Right now, we're just using dual antiplatelet, I think, post-TAVR. We don't have
to... for short course, and then we have to follow on only single antiplatelet for long course effects.
So there's another question on the hemodialysis. Like I said, if the patient doesn't fulfill the 2 criteria, you do use 5 milligrams in dialysis patients. There were a number of questions about edoxaban and high creatinine clearance. I didn't want to go into this, but do you want to comment on this?
I don't get the question. Actually, edoxaban 60 milligram was studied in GFR.
Yeah, I'll answer this. I will answer this. There is, they found that in those patients with very high filtration rates, the efficacy of edoxaban is a little bit reduced. But then when the FDA went back and looked at the other NOACs, such as rivaroxaban and dabigatran, they found the same thing. But I don't think clinically it really matters.
Yes.
Okay. Any more questions, Rania?
What's the difference?
There was somebody's asking about in renal AF trial for apixaban showed less benefits. No, all the data shows that the benefits with apixaban are better than warfarin also in renal patients. All the sub-studies as well and all the secondary analyses, but there's no prospective published data yet in this group of patients, but I think there are some studies ongoing.
You mean head-to-head comparison between the different NOAC?
No, I'm talking about the use of apixaban in patients with low creatinine clearance.
Okay. There is a lot of numbers of case studies published already, but there is no randomized fashion.
Or randomized controlled trials, yeah. The other hormonal therapies, Dr. Lal, don't cause a thrombosis. This other one, that besides tamoxifen, what's the other one? The AstraZeneca drug. What is it called? I can't remember. It's a tablet or something.
Yeah, there is number of tablets are there nowadays. Oral tablets, hormones. We call it the letrozole, anastrozole, AstraZeneca, anastrozole.
Anastrozole. Does that cause increased thrombosis?
The rate of thrombus is 1/3 as compared to tamoxifen. Tamoxifen causes suppose 6 to 10%. This causes 1 to 2%. It's very low.
Because that patient you mentioned, Walida, I don't know if I saw the same patient or not, but I had a similar patient.
Maybe.
And she had a thrombus in the right atrium, and she was a breast cancer, and
I will share with you the MRN tomorrow.
She had a PIC line as well, but it wasn't related to the line. But she was on the other one. She was on the astinazole one, this other thing.
I will share with you MRN tomorrow, inshallah. But I have a question, Dr. Wael. So now, patient with atrial fibrillation, and he has a stroke, and what to do next? So the patient is compliant. There is no question about compliance, but he has a stroke, and there is no evidence of intracardiac clot, and it's clearly embolic. So what to do next? To add another antithrombotic agent, or to choose another anticoagulation agent? What to do?
Yeah, that's a good question. I have 1 or 2 patients that this has happened. They have had a stroke on a NOAC. What I have done, and it's not based on any data except the RELY trial, and the RELY trial showed superiority. So I have put them on dabigatran 150.
150? Yeah, good idea. Very good. Yeah. Level of evidence C.
Yeah. And also, if it happened, you had to check the level as well, with the previous, deox. Maybe it was subtherapeutic level that time. This is also important. As you mentioned, each patient is different. Dosage is different. Their PK and PD is sometimes different in some patients. So maybe they have subtherapeutic level. That's why the patient developed a stroke. This is also important. Switching is good. Naturally, one is not working, you have to switch to other one. In these scenarios, actually, when any patient with one deoc, they develop any venous thromboembolism in our oncology patient, what we do actually, we switch to low molecular weight heparin, and we take, this we do in our practice. Lot of patients we do, which is a regular practice we do it.
Yeah, because you guys have a lot more experience in that, obviously.
Yeah. Good experience.
Okay. I think with that, we'll come to an end. Thank you very much, Dr. Ammar, Dr. Walid Tahlawi, for your excellent presentations and discussion. We thank Pfizer, and we look forward to you in the next Circulate. Thank you very much, everybody. Thank you.
Thank you so much, Dr. Wael. Thank you, Dr. Ammar, and thank you, Rania, and thank you, Pfizer.
Yeah, thank you, Dr. Wali, Dr. Wael, and Rania, and especially, the people who are attending us and tolerating us and asking the questions. Maybe somebody will get benefit of it. Thank you very much. Good night.
Thank you. Good night.